All right. So session two, day two, and we've got Joyce McHugh here sharing with us here in a couple minutes. Just want to, when I had made this announcement last session, there weren't a lot of people in the room yet, but I wanted to make sure you were aware. So the recordings that are from yesterday's sessions are all actually live on that day one tab in the auditorium. And so if you missed 15 minutes, if you missed an entire session yesterday, make sure to go in there and get caught up. And then again, with attestations, those will go out via DocuSign during that last session, and you'll get it sent to the email that you registered with. And so just keep your eyes out for that in your email inbox at the end of the day. We're going to move into our next session with Joyce McHugh. Joyce is a licensed clinical social worker, legal guardian, and certified care manager working in the Boulder, Colorado area. She has been with Advocate Care Services for 20 years and now serves as the owner of the agency. Joyce has dedicated her career to advocating for and supporting protected populations, helping individuals with dual diagnosis navigate complex medical and mental health systems. She actively works to increase awareness of the role of guardianship in medical and legal decision-making, collaborating with state agencies, local facilities, and healthcare providers. In addition to her full-time work, Joyce is currently writing a book on legal guardianship aimed at demystifying the process for professionals and families alike. And it's with pleasure I pass it on to Joyce. Joyce, the floor is yours.
Thank you so much. And I can't see everybody, but I'm glad people are here. It's an important topic. And we're going to dive right in because we're going to cover a lot of ground. And so when I first started this particular presentation, I had run into several times with issues getting somebody who was in a crisis the help that they needed. Because in Colorado, and I think it's probably everywhere because it's based on the DSM-5, dementia you used to be able to get somebody help by taking them in for a psych eval for dementia, and now that's listed as a medical condition. So you have people who a lot of times have been diagnosed with mental health issues that are now experiencing dementia, and you've got a real sticky situation sometimes when the behaviors begin to pop up. So we're going to cover quite a lot of ground. Also, if you have questions, I don't know if I can hear you if you unmute yourself, but certainly feel free to pop them into the chat throughout my time of talking, because sometimes if we save them all till the end, I get to the end and I can't address everybody's questions. So feel free to pop those into the chat. Good morning. I hope everybody's had or has their coffee or whatever gets you going, and we're going to start. Let's see. Oh, there we go. So the learning objectives for this are, we're going to learn to determine the pros and cons of a primary diagnosis. And by primary diagnosis, I'm sure most of you know that you might have a client that's diagnosed with an earlier diagnosis in their life of schizophrenia or schizoaffective or bipolar disorder or any one of those kind of classic mental health disorders. But they also now have a diagnosis of dementia and there's several different kinds of dementia. We all know that present in different ways. We've got Lewy body, we've got Wernicke's, those different kinds. So once you've got some primary diagnosis and you've got two different kinds of behaviors, we're going to look at the pros and cons of choosing a diagnosis. And we're also going to identify the different treatment and placement options for each diagnosis. So dementia, the classic placement is maybe memory care, but that's not appropriate because of behaviors. Do we need long-term care? Will a facility accept them with the mental health behaviors that they're presenting with? So we're really going to dive deep into sorting through a lot of that. And then we'll discuss and apply the ethical considerations of the options. So we're going to cover a lot of ground. So medical or mental health what's the difference? Because sometimes when we see the client as this whole person, but they're becoming divided into these two different diagnosis and placement options. And if we're being realistic, when facilities are considering somebody or we're looking at which diagnosis to pursue, since they don't know our person, sometimes what they're basing it all on is the diagnosis. So the mental health diagnosis, what's the difference? Mental health is a process that identifies a mental health condition based on its signs and symptoms. So a doctor or other mental health professional will consider a number of factors when making a diagnosis, and that's including their symptoms, their experiences, their thoughts, their mood disorders, disruptions, and behaviors. Also critical in a mental health diagnosis is how long a client has been experiencing those symptoms. Some are based on as little as 2 weeks, some as long as 2 years and beyond. So how long has our client been struggling with these symptoms? And then the impact, how are the symptoms affecting their life? So those all fall under, if we look in the DSM-5, those are all going to fall under our mental health diagnoses. Medical is more the process of identifying a disease, a condition, or injury from its signs and symptoms. And most of these one of the ways I tend to think of this is, can I see it on a health history through a physical exam, tests such as blood tests, imaging tests, biopsies? Those things are used to make a diagnosis. It's interesting to me that dementia in all its various forms, when I use that word in this, I'm using it as an umbrella term for all the dementia types that fall under that diagnosis. A dementia diagnosis, interestingly enough, is diagnosed much as the mental health one is, based on their experiences, their behaviors. We tend to think of the early signs of dementia as, mom or dad or grandma or your client putting their keys in the freezer and taking ice cream out to the car, when that's really not a typical early sign of dementia. But it is classified as medical. So when we've got this dual diagnosis for these clients, it gets really complicated when we're talking about pursuing treatment and placement. And sometimes, as I'm sure, and I don't want to make assumptions, but if you're a guardian, I think you've probably run into the issue that sometimes you have to wait for it to get worse before you can make it better, particularly with mental health issues. And if you're considering a placement in a facility or a treatment option in Colorado, one of the things that we cannot do unilaterally as a guardian is place somebody in mental health or substance abuse treatment involuntarily. What I can do is get them into the hospital for an evaluation and let the psych team or the medical team make the decision about treatment, and then I can agree to it, but I can't place them. So sometimes if they're not going to meet that standard criteria for involuntary treatment, I have to wait till it gets worse before it gets better. Now with dementia, when you're talking about possibly removing somebody from their home or putting caregivers in a home that they really don't want, but as guardian, you need them. Sometimes the steps that I've certainly taken as I'm waiting for it to get worse before I can make it better, where the courts have this standard that I have to meet in terms of failure to thrive or the home environment or something before I can actually get them in for an evaluation. I've certainly disabled stoves, I've disabled cars to keep people safe, but they haven't met that standard. So some of the signs of waiting for it to get worse before we can make it better is my client is not unstable enough for, okay, I see somebody said we have Joel's Law for involuntary detention. I'm not sure what Joel's Law is. So if you want to expand on that a little bit, that's great. But I'm sure there's a standard that they have to meet behaviorally wise for involuntary detention. If your client is not unstable enough for involuntary detention. Mental health diagnosis, a lot of times in various states that I've worked with, what I run into a lot, even though somebody's really not doing well, is they have the right to live that way. They have the right to make these choices. They have the right to fail, which is one of the hardest statements to deal with as a guardian. This person has the right to fail. They do, but if they're not able to make decisions in their own best interest, somebody else popped in, it's very difficult to get a court order under Joel's law. I find in Colorado, we have to have clear and convincing, or for the attorneys in the room, a preponderance of evidence that this person is a danger to themselves or others for an involuntary hospitalization. And sometimes if their diagnosis is medical, we also have to wait for it to get worse before we can make it better. And some of that is somebody with dementia who's not eating enough because they're not remembering to eat. They don't have a way to get all the groceries that they need, or they're not taking care of wounds, or they're neglecting their personal hygiene. And we really, if it's borderline, chances are authorities are not going to make a decision to do something involuntary with them. Now, if we can convince them to get an evaluation, that's different, but we're not going to get an involuntary one until it's really pretty egregious and obvious that they're failing to thrive or that they are a danger to themselves or others. So at the time while we're waiting, they're not a danger to themselves or others. And community resources like ambulances either cannot or will not help. Part of how I came up with this presentation is I had a client who had both medical and mental health diagnoses and was using meth, totally out of control, throwing rocks at his own apartment, his own condo, breaking all the windows. And the ambulance driver that came, because I couldn't write my own holds yet. Now I could have written a hold for him now, but I couldn't then. They refused to transport him, saying he wasn't presenting a danger to himself or others because he was throwing the rocks at his own apartment. And I said, well, he's broken all the windows out of his condo, so it's not habitable. It was winter in Colorado. But they would not agree with that and did refuse to transport him that day. And the police would not do anything about the fact that he was smoking meth in his apartment or in his condo, because he has a right to do what he wants in his own home. And there wasn't enough there under their guidelines to arrest him for possession because there wasn't enough to be prosecutable and win a case. So it was really frustrating that the health and well-being of my client was completely out of my control, even though I'm their guardian, and that they were still saying it's not bad enough. So sometimes we have to wait for it to get worse before we can step in to take the steps to make it better. Beth, I'm glad you've got a neurologist to do that. That's a great step, is involving outside people while you're waiting to get some diagnosis, if you can convince them to go to the appointment. A lot of times the people that I work with know what I'm doing or angling for, and they won't attend appointments. So one of the things that we did a lot of with my fellow who had thrown the rocks at his own apartment is get comfy with calling 911 for your person. Sometimes I know full well when I'm calling 911, they are not going to transport my client involuntarily. But what I am creating is a documentable trail for my eventual petition for involuntary, or my eventual support for my involuntary hold for this person. So with this particular guy, and I'll refer to him, throughout this because he is a case study, we had a run of 3 weeks where the police were there every day, sometimes multiple times a day, because other people in the complex were calling on him but the police would come and say, he has a right to behave how he wants in his own apartment. He would yell at people, but he wasn't threatening them. He wasn't a danger to them because he wasn't violent. It can be really, really frustrating. And Connie says here we would make an APS report. I am going to get to that, but that is another great tool, is calling APS. In Colorado, we're mandatory reporters, so we do have to call APS. So getting comfy with those. Who's calling 911? It can be outside people. For a while, I had neighbors calling me at all hours of the night. Hey, he's walking around outside talking to himself. Okay, call 911. I'm not coming over there right now. There's nothing I can do. But every time there was police contact, it was documentation that he was not doing well. And Byron says he had to wait for a client to decompensate. And that's exactly what we're talking about, is letting them fall apart. Are there charges pending against the client? I've also had to, when I knew there was client charges against a client or warrants out against a client, I would call the police. If I can get them into jail, they're going to understand that he's not stable and involve mental health. So I'm going to come at this with every resource that I can for trying to get this person help. And again, this is both medical and mental health. One of the things here that's really iffy is substance abuse can be considered, it's in the DSM-5, so it is mental health, but the symptoms, and here's where we want to be careful about bringing these, not letting these two get too far separated. The symptoms can present a medical crisis, especially if somebody's trying to drink themselves to death. I had a client who tried to drink himself to death on Keystone Light beer. And what happened was he had to ingest so much of the fluid that he caused a stroke and a heart attack by the sheer volume of fluid. And that was a medical crisis. So we want to make sure we're really making accurate lists of what's the medical presentation and what's the mental health in light of all these symptoms that are presenting in their behavior. So are there places that they visit regularly that you can contact? I've gone to the local convenience store to say, hey, I'm the guardian for this person. I know they're over here every day getting sodas. There's a warrant because they've stolen from you. Here's my card. Would you be willing to call me if they're in here acting out or having an issue? So if there's regular places that they visit that you can contact, by all means, contact them. Every source that you have as a source of documentation is a good way to do that. Somebody saying that we had a client keep getting kicked out of motels, but mental health could not help. Well, we found him a new motel. We had to wait till he was kicked out. I've certainly had that happen before, and then word gets around in the town and motels won't let them register. It's not a problem for me all the time, because if they don't have an ID or a way to pay, a lot of times the motels won't take them. And so also possibly working with the district attorney or the public defender, if they've got charges, if they've got warrants. I was told recently, a fella of mine, this case study that I'm talking about, had 7 warrants out because he had shoplifted and threatened somebody in a convenience store. So I thought, well, this will be an easy one to get him in, to be able to get him some help. And I called the police and said, hey, he's got 7 warrants. Here's where he is. Can you come and get him? And they said, no, that's not how warrants work, which maybe I've watched too much TV, but I thought if somebody had a warrant out for him, the police would come and get them if they knew where they were, or they would actively search for them. What they told me was the warrant is if they have police contact and run their name, they've got a warrant, they'll take them in then, but they won't actively search for them or go pick them up. which was a surprise for me, but good information because it's not an avenue of getting them in. And so is jail or possible incarceration a factor? As it turns out, he did have police contact. They did arrest him on the warrants. He kind of flipped out at a homeless shelter, and they had him arrested. So he is in jail, which I go to his hearings because they want me to sign for his bonds, which I am not going to do because he won't show up. I don't want to be on the hook for the money, but also in jail, he is safe. He's not able to use, and I've been able to have a mental health evaluation done while he was in jail. So calling 911, a lot of people would be very reticent or reluctant to put their client in jail. It seems so counterintuitive to what we're trying to do, which is the best thing for them. But sometimes that is the best, safest place for them. So here's the case study I was talking about. This fella, he's diagnosed schizoaffective, and we're going to use these two diagnoses for him. Current substance use and abuse, difficult family relationships is really putting it mildly. They're all fractured. His mom in the condo that he was throwing rocks at, his mother had owned, and we ended up evicting him, which created a problem for me because at least if he had a place to live, I knew where to find him. When he was out on the streets and homeless, it was really iffy whether I could find him each day. If I can't locate my client, I can't help him. So one of the things we came up with was he has a rep PA that, a rep, payee, there we go, who manages his money. So how I ended up getting him to meet me regularly was I would give him $20 cash for food, but he had to meet me. We had to have a conversation, that kind of thing. So I was able to keep tabs on him that way a little bit. So fractured family relationships. His only friends were people that were sleeping while he had his condo in there because they were cooking meth in the condo and it was a warm, dry place to sleep. So these are mental health, his mental health issues. He had delusional, grandiose thought patterns. I'm going to get a job. I don't need you as a guardian. I'm going to clean this house. It was horrifying environment for him to be in. He couldn't meet his daily needs, such as food or hygiene. He was putting cigarettes out on the carpet. It was really rough. And former military, veterans are near and dear to my heart. His military service had really had an impact on his mental health. And he had no history of violence. Everybody said, oh, he's not violent, he's sweet as can be, which he was until he was using meth. And he did get his hands on me one day while the police were there, and it was a real problem. And that's a presentation for another day. So that's the mental health side of him. The medical side of him, he never worked regularly and inherited funds from his person. Now, Social Security indicates that you cannot withhold a client's benefit if they do not meet with you. With him being homeless, I wasn't withholding his funds. I wanted to give him money, but I couldn't do it if he didn't meet with me. He didn't have an ID. He kept losing his TrueLink card. So we really, short of handing him cash, had no way to actually give him his benefits. So that was in the chat. Going back to medical, he couldn't meet his daily needs, such as food and hygiene. He would, if I gave him $20, he'd go spend half of that on cigarettes and then buy a hamburger, Coke, and fries and be out of money till I wanted to meet with him again, or I could meet with him again. So they can't perform their activities of daily living. Again, the similarity between medical and mental health, there's a lot of them. The fractured relationships with adult children or parents, no friends, not performing ADLs, not meeting. So a lot of these really bleed into each other. I know I'm moving fast. I feel a little bit like an auctioneer. he's paranoid, very paranoid, was part of his both medical and mental health things. This person didn't believe in a doctor once he was out of the Army. He refused to see doctors, wouldn't acknowledge his mental health situation. But again, no history of violence. So the medical and mental health manifestations are very much the same. Mindy says our area has community paramedics and they've been very helpful, collaborative. They are a lot in my area, and every once in a while I get one. One of the ones that came actually this day, one of these days for these clients, refused to transport him based on his own political beliefs, which he just flat out told me that. Despite my paperwork saying I have the right to have a client transported for an evaluation, he wouldn't do it. And the police said, unless he says we'll do it, he couldn't. Most of the time, those paramedics are very collaborative, and I appreciate them and lean into them quite a bit. So what are the pros and cons of each diagnosis? We really want to look at that before we choose which one to pursue for treatment and placement, because they both have definite pros and cons. So for mental health, if we're going to choose the mental health diagnosis, the pros of that are it can allow for targeted interventions by identifying treatments supported by empirical evidence. So that would be certain medications for medical issues such as high blood pressure, congestive heart failure, those kinds of, there's some, definitely some medications out there for dementia. I've not had great experience with them. By the time I get a lot of people, they're so far down their dementia journey that the medications just aren't going to preserve enough memory to make it worth dealing with some of the side effects. The mental health does help get appropriate medications on board, can reduce anxiety over the unknown and give help. So many times our mental health clients really struggle with anxiety and do want to have some hope. It can allow connection with others with the same issue in the form of, if we can get them into I don't know if you guys have community reach centers or anything like that, but the community mental health agencies that'll provide groups that they can participate in to know they're not alone, therapy that they can participate in to try to navigate some of their mental health issues. If they have to change providers, there's a framework to begin with at an agency like that, and it really can alleviate a sense of isolation with their diagnosis, or even in not understanding their own behaviors. Jamie says there's an exception to the ITA as outlined in the RCW. And I presume because the VA is federal, it would apply elsewhere, for military has its own criteria for involuntary holds. Right, the person does not have to be active duty, and they do have to be attached to services with the VA. This person that I'm talking about is not attached to the VA. Our VA out here, our VAs are quite overwhelmed. And so I will often go at that from both sides, either through their traditional medical providers, community mental health organization, and with the VA. So the cons of pursuing the mental health diagnosis is the labels don't explain the underlying causes of mental health issues. So my clients got schizophrenia or schizoaffective. I don't know why, but I also don't know why certain people get dementia. So I listed that because I'm very much a why person. Being labeled with a mental disorder can cause individuals to feel abnormal and isolated and increase acting out behaviors, or definitely increase the possibility of increased substance use and abuse. The diagnosis and supporting medication can negatively impact obtaining licenses and jobs, particularly jobs requiring them to operate licenses. Elizabeth, I agree. We need to be very, very careful about labels. I often will share a diagnosis that's been given to somebody very sparingly and only with people who need it, who need to know, medical professionals, treatment professionals. If I have family members that ask that because they want to know or they're trying to be helpful, I will most often decline to share that. And so medication impacting getting licenses, jobs, those kinds of things. I've said to people, either as guardian or care manager, I'm happy to speak to your boss or somebody about what this means for you as an employee. It's very hard for somebody to get a job, but if we're going through a training program or a skills acquisition program, being able to have a conversation about the reality of their capacity to hold a job and what kind of job they can hold is a really important conversation to have. And you can have that conversation without attaching labels. And in some cases, an illness can be exacerbated by over-identifying with it till it becomes their identity, which I really, and these are other presentations on communication, but overly identifying with major depressive disorder or bipolar disorder to the point they're using it to explain their behaviors or their lack of motivation or lack of work. Not that that's not valid sometimes, but I think we all know somebody who has become overly identified with their diagnosis till it becomes their identity, not their diagnosis. And diagnoses and labels can really disregard the influence of short-term factors such as recent loss, family environment, or social factors. One of the great ones for this is depression, major depressive disorder, mood disorder. You know, if somebody's had a recent huge family loss, wouldn't we expect some depressive kind of behaviors in that person? It doesn't mean that overall they have this long-term diagnosis with major depressive. So we want to make sure we're really addressing what could be a very short-term situation and not making it a long-term factor in their treatment. And then a diagnosis is limited by its reliance on Western explanations and disregard for other cultural perspectives. And you're right, these beautiful human beings, Elizabeth, deserve our ability to look beyond the illness, which is, in Colorado, I am a licensed diagnostician. I have a DSM-5 because I had to buy it for school. I don't ever open it. I'm not interested in labeling my people, particularly people I'm guardian for, with something that puts them in a box. And so now we'll move on to the medical part of this. The medical pros of a diagnosis. Again, a lot of these are similar between the two. It allows for targeted treatment supported by medical research. When we're talking about mental health medications in particular, it's really essential to talk both about the medical and mental health side of the impact of those medications. Again, it does help get appropriate medication on board. I'm really going through the similarities of the pros and cons of both of these, and can reduce anxiety over the unknown, give hope, does allow connection with others with the same issue. Particularly, you know, there's support groups for people with cancer, for caregivers of people with dementia. So it does allow for the connection for people walking the same path, but not necessarily having identical experiences. Again, if they change providers, there's a framework and it can alleviate a sense of isolation. So again, these are so similar for the medical and mental health pros and cons that we don't even really need to go through all of these again. Is it seems like in the work arenas, particularly, a medical diagnosis is much more palatable for an employer to try to understand and work with than a mental health one. And so there's an area where I might lean more into a medical diagnosis. Again, if I feel like there's a safety issue at all, it's a very different conversation. But if I've got somebody with bipolar disorder that's well managed with medication, they're not substance using or abusing, and they've had a recent back surgery that requires some medication that might impact their ability to operate heavy equipment, I'm really going to talk about the medical part of that with them more than the mental health part. So just understanding the balance of these two. Whoops, going the wrong way. So they're a lot the same. So what do we do now with this person? How are we going to get them help? Mental and mental health, pros, cons, behaviors, all of that can look much the same. So how do we decide what primary diagnosis to choose to pursue treatment and placement for? What are our mental health, and medical considerations? And there's two different things at play here. One is if we've got clients that are so impacted by one or both of these diagnoses that we're looking for either a treatment facility or placement, residential placement for the long term, this is where we're going to get into which of those we want to pursue for treatment and placement. So for the primary diagnosis, the consideration for facility or residential placement options are, what is the primary symptom? And here's where they can look the same. If I've got a client that has schizophrenia and Wernicke's dementia, and I'm throwing these out as very generalizations because every person's journey with both of these is different. I'm not trying to corral them all and say, this is exactly what it looks like and here's what you do. What's the primary symptom? I have people with these diagnoses that can get violent at the drop of a hat, particularly with the Wernicke's dementia, which is largely present in people with a former history of alcoholism, so former substance use and abuse thing. What is their primary symptom? Are they violent? What is their age? Some out here in Colorado, and I know a lot of the other states do it too, the licensing, unless you can get a variance for some of the facilities such as assisted living and stuff, they have to be at least 60 years old. I've had people younger than that need the services and had to really work hard to get an exception based on their age. And then the financial considerations about a facility, are they private pay? Are they Medicaid? Are they private pay for a while and I've got to find a facility that will keep them there while I spend them down and then they continue on to Medicaid paying? Not all facilities do that. Some are private pay. Once they're done with that, you've got to use them or move them. And what is the highest need for your client? Is that medical? Is it mental health? I've had people with very early dementia diagnosis, early 50s, and they are impacted enough that I've got to get them into a facility, but they've had lifelong mental health struggles. So is their highest need a facility that will work with somebody with hard to deal with behaviors? Or is it memory care for the fact that they're so impacted that they need the assistance that memory care provides? So the balance for me a lot of times is memory care. A lot of times those people are not ready for long-term care, nursing home type things. They can get dressed with the assistance of a caregiver. They can ambulate under certain conditions out to the dining room, but they need lots and lots of assistance with the activities of daily living. Very different than my client with Wernicke's dementia, who needs all of that assistance, but might have angry outbursts. I had a woman who seemed like this little frail old gal, but she could throw her walker across the room so fast. And so memory care really wasn't appropriate for her, even though she needed all that assistance. I had to really place her in a facility directed more at managing the behaviors that her mental health issues were manifesting. So also, what is the expected length of their placement? Are we looking to stabilize them on medication because of their mental health issues? Or is this a long-term care situation where I'm going to move them out of the home, let the conservator sell the home, or let go of the apartment, because this is going to be as permanent as of a placement as we can have with a client with these diagnoses? And then what are the future options? If I've got somebody going into a facility for assisted living, they can do some things on their own. You know, assisted living is kind of a misnomer. It's kind of medication management and making sure they get food, but they're in their place alone, trying to manage their ADLs. Is there continued care eventually? Does that facility have memory care available? Does it have long-term care, which out here is mostly another name for skilled nursing at that point? So what are my future options with that placement, not just to get them stable today? So those are some of the considerations for placement for facility options for them. So what kind of facility is best for this client? Are they a wanderer? Are they a flight risk? Should it be locked? The secure facility label varies some from state to state. In Colorado, I can't put somebody in a secure facility for treatment, but I can put them in a secure facility for their safety. So if somebody is so impacted by either one of their diagnoses that they are a flight risk or a wander risk, and we tend to think of those very differently, but at the end of the day, are they going to attempt to leave? Either because they don't want to be there, they think they don't need to be there, or they're just going to go check out what the rest of the facility is like. Are they a wander risk? So do they need memory care? We just talked about the ADLs or skilled nursing. Out here, one of the things that we talk about, and I've been to a lot of other states, that, you know, one of the questions somebody will ask is, what are their behaviors? They might not have any behaviors that are noteworthy in terms of this. So by noteworthy, if you make her mad, she will try to throw her walker at you. That's a behavior I need them to know before they even go do the assessment. Something not as noteworthy is they insist on wearing their shoes on the wrong feet. That's not a behavior that I have to figure out placement for. So really learning to identify what are the behaviors that you're working with this person. And is there an opportunity for community exposure? So many times somebody's in a secure facility and there's no opportunity for community exposure. And it's really a very hard placement for them because they're on that cusp. So can we have them in a least restrictive, less restrictive part of this facility with the option to move them into more restrictive as they need it? Again, is it long or short term? And then is a host home an option? A lot of times it is for developmentally disabled people, at least out here in the other states. So I never want to make assumptions about every state's laws, but is a host home an option? If I have people with dementia with limited behaviors, but still mental health issues, if they've got assets, I might try to place them in a host home with a family for a while. A lot of times that's a great option here. They get more one-on-one attention. And when they get close to spend down, then I can look for a facility. But I'm really looking to maximize their quality of life while they're cognizant enough to enjoy it and while they have the resources to enjoy it. So I'm not going to jump right away to, hey, they're declining, I'm going to put them in this facility or in memory care because they're close enough to need that. I really want to have them enjoy life as long as they can. So a host home might be an option. So really consider the different options that you have available for your client. And then the ethical considerations, Okay, they said, Mindy said, yes, we have AFHs here and companion homes, supported living for disability services. That is great. I'm not touching a lot on disability in this presentation because we're talking about not so much about developmentally disabled. I'm glad there's host homes, but those are available for people with dementia, or I have a gal with a head injury and mental health diagnosis who lives in a host home. And we've been through several host homes and we've had a couple long terms. So finding that fit, I love that host homes exist. I love that there's people in the world willing to have somebody into their home, part of their family, that may not be the easiest to deal with. So the ethical considerations, when we talk about those, can you tell us the name of the book you're writing? I'll get to that at the end. The relationship with other professionals and providers is such an important thing, that we develop our professional relationships with other professionals and other providers for networking, for support. It's also a great ethical way to have a sounding board, to be able to provide for your client, to gather more information. It's a good, wonderful, ethical thing to do. Always thinking about the least restrictive alternative. This one, I will say, is the one that sometimes I really struggle with, because sometimes the option between where I want to place them and less restrictive is enough that I really feel they're at risk, but can I take the chance on giving them the chance to do that? So I'll always really, even though I might say, here's the direction I'm going to go, I at least really need to explore that least restrictive alternative, less restrictive alternative. And we want our clients, to the extent that they can, to participate and have some self-determination in the choices that we are making, both for and with them. One of the things that I always say to clients when they say, why are you doing this to me? Like putting them in a different facility, or having to remove them from their home or take their car away from them. My standard reply to that, if they're cognizant enough to have the discussion about it, is, I'm not doing this to you. I'm doing this for you. Can we talk about what the benefits are? And at the end of the day, even if they don't agree with you, you've gotten to tell them your point of view. And I think it's really important for their self-determination, for them to understand, to the extent that they can, where you're coming from. And then the duties of the guardian of the person. We all have our court mandated. In Colorado, the authority of a guardian is deep and wide. The courts here think, if you're a guardian and you know how to do this, do it, and pretty much bother us the least amount possible with help in your decision making. Once in a very great while, I'll ask the court for direction on something, and it mostly has very little to do with my client, my actual client, and a lot to do with the ruckus and brouhaha that some well-meaning friend or family member influence is trying to exert over the process. Again, a whole other presentation. And decision making around medical treatment. Sounds wonderful. Might need to move to Colorado. Come on, Colorado. Every place we are needs more qualified, caring, wonderful guardians. Decision making around medical treatment. Again, I could talk all day about this, particularly when it comes to surgeries. Am I going to do a surgery for somebody? What is the age? What do the doctors say? Sometimes a friend or family member is really insisting on something. End of life decision making. If I've got somebody who, by the time they came to me, was incapacitated enough that they cannot make their final decisions, I want to learn as much as I can about what they would have wanted the end of their life to look like. And that's true for both mental health and medical treatment. One of the things I'll throw out, and I know we're going to run out of time, is that there's an attorney in Colorado who is making part of a guardianship order the idea that, I don't know if Washington State has it, Colorado has it, Oregon, a bunch of other states, but the right to die on their terms. This attorney has end of life documents that say, if I have a guardian, I hereby, while I'm of sound mind, give them the authority to make the decision about ending my life under the right to die statute. I have no idea, and I would love to have an open discussion with other guardians if I would be able to pursue that for somebody. But if that's something that they were vocal during their life that they wanted, hey, if I get this and I'm this incapacitated, I don't want to be here. That's a rough one. You know, we all make decisions that end people's lives or certainly hasten their passing. But would I, as a guardian, feel okay with handing them the medications to swallow that are going to end their life in 10 minutes? So all of these things, decision making around medical treatment, require a lot of ethical consideration on our part. Seek out the opinions of others, certainly in your lives. So the ethical considerations we have to put in here, both for CEU purposes, but also we really want to make sure that we are operating in an ethical way as guardians. Wow, okay, I made the time thing and left some time for questions. Oh, sorry, this is Leah, not Mindy. MAID is very interesting and would love to hear more about this. What is that? I don't know what that acronym stands for. Does anybody have any questions, comments they want to throw out before we wrap up and let you get on to your next session? Oh, medical assistance in dying. Hey, I should have figured that out. It is very interesting and is going to become a really trending topic for guardians, because on top of the decision making we already make, which is sometimes so reactive to the illness or the process that's taking place in our person's body, and we're making decisions either in support of what they've already decided, right? Or in reaction to what's already going on with their body. I had a guy, as an example, when I got him, he was unconscious on some railroad tracks here and never regained consciousness. So I had no opportunity to talk to him. He was homeless, no idea what he would have chosen until one of the attorneys, this is why it's important to talk to the client about what they want. Again, whole other presentation on having that conversation with both your client, maybe their trusted people, their attorney, what have you. But I had no opportunity to find out what this guy wanted, but he never regained consciousness, was in a hospital. They got him stable, but what happened was he kept getting pneumonia after pneumonia after pneumonia because no coughing, can't clear his lungs, and he was laying down a lot of the time. He wasn't on life support. Go in, it's like he's sleeping. They were tube feeding him, ended up moving him to a respiratory hospital. So this is talking about the reactionary. And one of the attorneys that did the petition happened to mention to me that he had spent some time in a local homeless shelter. So I called them, hey, can you tell me anything about him? Ended up getting some good information, and that he was very outdoorsy, had said to people, when his time is up, it's up. He doesn't want to linger. He doesn't want to have anybody prolong his life. So what we ended up doing after his fourth or fifth or sixth pneumonia is switching to comfort care and letting him go, because they had determined he had no chance to regain consciousness. He was slowly wasting away by the tube feeding. And so that was a very reactionary decision. But had I known earlier that that's what he would have wanted, I probably wouldn't have let him go through all the pneumonias that he did. So yours can appeal for direction from the court. So as long as there is good evidence, the client wanted this even prior to incapacity. In Colorado, we don't have to go to the court for direction. Again, the courts say that you're responsible for this person now. I had a lady, and I'm gonna do this really quickly. Just yesterday, tell me, time to turn off mom's pacemaker. Mom lives in an assisted living facility and is still pretty fiery. And this gal's telling me turn off her pacemaker. I'm not going to do that right now. So it's it's kind of reactionary, but lots of discussion to be had. And I'm glad that you can ask for direction from the court. Again, in Colorado, we can make that decision. So facilities and hospice services will often be a barrier to end of life issues depending on their religious base. Thank you, Claire. Here, I found one hospice that I love working with, and I'll use them all the time because those things are not an issue. They're very realistic. End of life is coming. How do we make this the best that it can be for this person? So I'm going to wrap up. The working title of my book is Guardianship, How and Why We Do What We Do. And that's kind of a working title to tell you how we do it, why we do it, and the process of doing it. And so I'm hoping to get it into final edits here in a couple months. I was telling Luke at the beginning, for a couple of years at conferences, people have been asking me for both a podcast and some daily support in the form of social media. So I told him, I'm getting those things up and coming. I'll shoot it to him when it's ready and he can run it out to you guys. You're so welcome thank you for having me. I love doing this. And I'm hoping to get to throw out a few more presentations to you guys on a much less formal basis. Just here's when I'm doing it, log in, and we'll do that. So I think I'm skirting in like 30 seconds under my time, Luke.
That's perfect.
Rare
Thank you,
for
Joyce.
me.
And yeah, and one of the things we were talking about prior to this session starting was, and I guess we haven't announced that, but I think most of you are aware of it here. So we do our end of the month, last Tuesday of the month, from 9 to 10 a.m. We have coffee chats. And so kind of an informal gathering of guardians and talking about current issues and challenges, and sometimes there's specific topics that you'll engage in. But Joyce had mentioned that she'd be willing to come potentially give her presentation at one of those as well. So we'll coordinate and touch base afterwards, and find a Tuesday that might work, and have Joyce come back. So thanks so much for all your information, Joyce, and we're going to wrap up our session now. One thing I want to make you aware of, so a few of you were asking for information or the PowerPoint from Peter Wall's presentation on Secure Act 2.0 from yesterday. He emailed us, sent it over just this morning, and so that's over in the resources tab on the conference platform. Thanks again, Joyce. Thanks, everybody. We'll see you here in 15 minutes.
Thank you. Thanks, everybody.